Hello, everyone. Thanks for joining us for this Part B Hospice and Palliative Care Common Rejections and Denials webinar. This webinar is designed for those who submit claims on the CMS 1500 claim form or the 837P electronic claim. My name is Mary Mucko. I am a specialist on the Provider Outreach and Education team at WPS Health Solutions. I will be your speaker today, and assisting me is my friend and colleague, Ellen Barra. We begin this webinar with this disclaimer, and we do include it in all our education. We do so to remind learners that although we made every effort to provide current information that is correct, the information is subject to change. It is on the CMS website where you will find the Medicare rules that determine final coverage. These laws, regulations, and rulings will always prevail. We will provide responses to questions based on the facts given. One last reminder, CMS prohibits recording of this presentation for profit-making purposes. We are recording this webinar and we will post it as an encore presentation. You can stay informed about new postings of the latest encore presentations and other education events by reading the education news we post each week on Wednesday. We'll also be posting the recording to our YouTube channel. Here is our agenda for today, and when we advertised, we said that we will, for specialty type 17 providers, that's the specialty that identifies hospice and palliative care, we will define rejections and denials. We're going to review data for those common rejections and denials. We'll discuss how to fix and avoid both rejections and denials, and I will be providing some resources as well. In the materials for today's webinar, there are many embedded links that will take you to all of the resources that I'll be talking about during my presentation today. Here is a copyright notice, and we provide for you the copyright notice for the American Medical Association. Your continued participation in this webinar infers that you agree to the terms of the copyright notice. Should you not agree to acknowledge this copyright notice, you may disconnect now from this webinar. To fully understand rejections and denials, it's really important to recognize the path that a claim takes, or what we like to call the life of a claim. This is a simplified graphic on how a claim gets into our system. The provider or supplier renders the service, submits the claim, but the system might reject the claim or batch of claims. And when this occurs, Medicare generates and sends a 277 or 999 report. This slide describes that claim submission in a bit more detail. Most providers submit claims electronically. Very few actually qualify for a waiver under a law that prohibits Medicare from making payment on any claim when it is not submitted electronically. Now, to confirm claim receipt, providers should use the 999 report, use the 277 report for more specific information about the claim. Our electronic data interchange, or EDI staff, created a companion guide for the Medicare 276 and 277. This is a guide that helps clarify. It further defines data content requirements for an electronic claim. Now, based on these reports, the 999 and the 277 report, you'll know if the claim is rejected or if you need to correct or resubmit. Here is a simplified graphic that shows what happens to a claim that Medicare deems as unprocessable. You'll see it's an unprocessable rejection. Of course, the provider provides the service, submits the claim, but something's just not right. Something's invalid, incorrect, or even in an incorrect format. So the remittance advice generates to explain what is missing or invalid or incorrect. This slide shows a side-by-side comparison of a claim rejection and claim denial. And I think that a lot of us, we even do this in our office sometimes, and we correct ourselves. We use these terms interchangeably, but they really are very different things. A rejection is not the same as a denial. So if you look at the left side of this claim, you will see that a rejection is unprocessable. It is returned on the front end because something's missing or invalid or incorrect. For these claims, because they're never really adjudicated, there are no appeal rights. What you need to do is resubmit the service, fix it and resubmit it. There are some codes that print out on the remittance advice that I'll talk about in just a minute. For rejections, you will see an MA130 and a CO16. I will talk about those a bit later. For rejected claims, the patient is never liable because the claim is never adjudicated. Denied claims, on the other hand, are adjudicated, and we deny claims because they fail to meet payment criteria. These could be criteria that are based on laws or statutory requirements. Perhaps a claim denies due to medical necessity. This includes utilization or frequency parameters. Sometimes claims will deny for other things such as eligibility. Perhaps the beneficiary isn't eligible on the date of service, or the provider's not eligible on the date of service. For denied claims, you will find an MA01 on the, it should say remittance advice there. It's on the remittance advice, but that code, that MA01, provides appeal rights. Now, with very few exceptions, denied claims do offer a Medicare provider the right to an appeal, but there are some exceptions. They are few. For denied services, the patient liability is determined. Here then is a graphic that shows the path for a processed claim or one that's been adjudicated. The service is provided and submitted to Medicare based on the edits and audits. The claim will either pay or deny. And then that remittance advice is generated. Let's talk about that remittance advice just for a bit here. Sometimes we call it the remittance notice. You might hear some of us refer to it as the RA. Some people just shorten it up and call it the remit. Most providers will receive an electronic remittance advice, or ERA, as opposed to a standard paper remittance, the SPR. Now that ERA is going to include details about the transfer of funds and payment processing from the payer, in this case Medicare, to the healthcare provider's bank. And depending on how the claim processed, it could also include information about any adjustment that's made to the claim. It might include or would include denial information if a claim is denied. It could also include information about something that's missing. It provides notice about refunds and offsets. So a lot of information is available on that remittance advice that providers should be referring to. There are codes on the remittance advice, and these provide information about the claim. I talked about codes earlier, that MA130, the CO16, the MA130. Claim adjustment reason codes, we call these CARCs sometimes, or CARCs, will explain why a claim paid differently than what was billed. Remittance advice remark codes, we call these RARCs or RARCs, will provide more details about an adjustment that's described by a claim adjustment reason code. Provides more information. Another type of code that you will see on the remittance advice, or the RA, is a group code. I talked about one of them earlier, the CO16. And group codes convey the financial responsibility for the unpaid portion of a claim balance. A CO group code reflects contractual obligation. This means the provider is liable and can't bill the patient. A PR group code means the patient is financially reliable or responsible. You can find these code lists on the Washington Publishing Company website. This is a company that maintains those codes for CMS. You can find the lists, as I mentioned, on the WPC's or the Washington Publishing Company's website. The links are embedded here for you. Now, we understand that some of the codes may be cryptic or even out of date. They might include some out of date information, such as an out of date acronym. We can't control that. It is the Washington Publishing Company that maintains those codes. I got a couple of comments and some survey feedback. That's that survey that I mentioned to you earlier. You'll be able to complete at the end of the webinar. And on that survey, the learner said that, Mary was using outdated acronyms. I am telling you now that these outdated acronyms are part of that reason code that prints out on the remittance advice, and WPS can't change it. I'm giving you the information that you're going to actually see on the remittance advice. So while I understand that they are outdated, I did want you to have the information that matches what's on that remittance notice. Now, after reviewing that RA, you're going to need to choose the action that you need to take to either fix, correct, or resubmit, or even request an appeal. So for an unprocessable or rejected claim, you will need to fix that error and resubmit the claim. Or if the claim or the claim line denied, there could be other multiple actions to choose from. You may be able to simply resubmit the service if a claim denied. You might use the clerical error reopening or CER process, sometimes we say CER process, to correct a clerical error. And CMS defines clerical errors, including minor errors or omissions, as human or mechanical errors on the part of the party or the contractor. I'll talk more about that process just in a couple of minutes. Another action to consider for a denied claim is an appeal. The remittance advice will provide appeal rights. And remember, I mentioned earlier that with few exceptions, there are appeal rights for denied services. Registered users of our secure portal or transactional portal can render a clerical error reopening, or they can use that self-service technology to request an appeal. These self-service tools really do offer the most efficiencies. We do have a portal user manual that provides illustrations and step-by-step instructions on how to use these portal features, as well as the other functionalities of that secure transactional portal. Here are just a couple of CMS resources that I did want to include for you. These pertain to the remittance advice. If you're looking for more information about the remittance advice and the electronic funds transfer, these are some great options for you. Both of these are CMS resources. Next, I want to talk a little bit more about when you need to correct or appeal the MAC's decision, and MAC is an acronym that stands for Medicare Administrative Contractor. WPS is your MAC if you are a provider who performs services in Iowa, Kansas, Missouri, Nebraska, or Michigan, or Indiana. We are the Part AB MAC. So you have the right to appeal the MAC's decision on denied services, or you may need to simply submit a corrected claim. And that's what we're going to talk about now. I mentioned earlier the clerical error reopening or CER or CER process. I told you that I'd share more details. This is the process to correct those human or mechanical errors. Clerical errors or minor errors are limited to errors in form and content. They are not omissions, such as failing to bill for certain items and services. Your handout includes the link to a wonderful resource. It's titled How to Request a Clerical Error Reopening. And I called it wonderful because it really includes a lot of great information. It provides examples of acceptable clerical error submissions, such as a mathematical or computational mistake. Perhaps there was incorrect data entry, computer errors, or maybe a transposed procedure or diagnostic code. So there are examples of acceptable clerical error submissions, but there's also some great examples of what cannot be processed as a clerical error reopening on that resource that's shown there in the very last bullet on this slide. Comprehensive error rate testing issues cannot be done as a clerical error reopening. Wrong payee situations, provider enrollment issues. These are just some of those situations where you cannot use the clerical error reopening. There's also some complex claim situations listed as examples in that resource, such as when you bill a not otherwise classified or NOC code. And there's also a list of certain modifiers for which you cannot use this particular process. Some of them are 22, 53, 55, and so on and so forth. You can use the self-service portal or you can request a clerical error reopening via phone or fax. And remember that portal user manual does provide instructions. Now, for denied claims, your option would be an appeal. There are 5 levels of appeal. There are time limits for submitting and for completing an appeal. And there's also some monetary thresholds for filing for a couple of the appeal levels. Those monetary thresholds are referred to as the amount in controversy, or the AIC, and this amount in controversy, these monetary thresholds, apply only to levels 3 and 5. Now, based on law, these monetary amounts can change from year to year, so you need to pay attention to that. You can check out a resource on our website. It's called How to Appeal a Claim Determination. I have that actually on the next slide. And it provides details about who can actually request. I'll go to that here in just a minute here. Who can actually request an appeal? The beneficiary or their representative may request an appeal for any service that's processed for them. Providers and suppliers, though, can appeal services for which they accepted assignment. For unassigned claims, providers and suppliers can act as the beneficiary's representative. However, the beneficiary does need to sign an authorization statement. Providers and suppliers can also request a redetermination. That's that level 1 appeal, the only appeal that's done by the MAC. On an assigned claim, if Medicare denied that service is not reasonable and necessary, and that would include your frequency or utilization parameters, or when the provider or supplier billed in excess of the limiting charge. And in such a case, when billing in excess of the limiting charge, of course, the provider would need to refund any amounts that they've overcollected from the beneficiary. Remember, we recommend using self-service options for more efficiencies. Now, in addition to that resource I just talked about, how to appeal a claim determination, there's another resource I want to share with you, and I do it frequently because it's one of my favorite resources that I refer to, and it is the appeals process flowchart. It includes both the standard and expedited processes for appeals. You see it there on that slide, the right-hand side. The standard process, which you see on the left, is for parts A and B, and the expedited process applies for some, not all, Part A only appeals. So you have each of the 5 levels here. You have the time frames that I talked about. How many days do you have to file that appeal? How many days does the contractor have to make their decision? So it's very, very informative. This also includes those amounts in controversy for levels 3 and level 5. You can see currently for this year, the amount in controversy has to be equal to or greater than $180 for a level 3 appeal. And for the level 5 appeal in federal district court, the amount in controversy is $1,840. The next portion of this presentation then includes a discussion of the data that I used to provide or reveal during this webinar the most common rejections and denials for Specialty 17, that is hospice and palliative care. The data that I'm sharing is Specialty 17 claims that were submitted to WPS for Jurisdiction 5, Iowa, Kansas, Missouri, and Nebraska, and Jurisdiction 8, which is Indiana and Michigan. So all 6 states, Specialty 17, while the dashboard does allow us to drill down by a specific state or states and even counties, we can drill down to a county level. I pull data for the entire jurisdiction, and that's what I'm sharing now in the next few slides. For those of you that may be wondering what Specialty 17 is, I mentioned that a couple of times now. It is a 2-digit code that's assigned to WPS providers when they enroll. And during enrollment, providers will self-designate a specialty. While a provider can designate a secondary specialty or even a third specialty, it is only that primary specialty, the one self-designated, that is used during initial claim processing. There are some situations where a provider will request an appeal and stipulate or show their secondary specialty, and then Medicare may be able to allow payment. But we use the primary specialty only in initial claim processing. So Specialty 17, as I mentioned, is hospice and palliative care. I pulled data for submission dates. You see it here on the slide, April 1 of 2024 through March 30 of 2024. So April, May, and June of this year. And it says there, that last bullet, that the data was last refreshed on July 12 of 2024. So what that means, the data was last refreshed, means any claims submitted for that date range you see there after July 12 of 24 will not be included in the data I will present. And, keep in mind that we pulled this information and published this handout on our website a while back already. So that's why it's July and nothing, not a date more recent. So let's talk about, or allow me to reveal, the common rejections by reason. Remember, I talked about reason codes. They are maintained by the Washington Publishing Company. WPS does not write these reason codes. So sometimes they may seem a little cryptic. They may have an outdated acronym in them. We can't change that. We recognize that it's outdated or even cryptic, but we can't change them. There is on their website, that Washington Publishing Company's website, there's a mechanism that you can contact them to make suggestions if you'd like. So most often when a claim is rejected, you're going to see that top denial on it, in addition to more reason or remark codes. The claim lacks information needed for adjudication. Look to those other reasons on that claim or on that remittance notice to see what it is that's actually missing. So this shows commonly on the remittance notice, but there's always additional codes as well. So missing information needed to adjudicate the claim is also one that you will see often. It doesn't tell you specifically what's missing. What you need to do is take a look at some of the resources that I'm going to talk about in a little bit. Look at their remittance advice. Look to see if there's other rejection reasons. Look at the claim itself that you submitted to see what is missing. You can take a look at the CMS claim form instructions. It goes item by item of a paper claim. There's also a paper crosswalk code, or paper crosswalk, and I'm going to show you that right now. I've included in your handout the link to this crosswalk. You see the title here. We just call it the crosswalk. It's a lot shorter than saying the entire name of that. But on the or in the CMS Internet Only manual that has claim form instructions, it goes item by item of a paper claim and tells you whether the information on that claim is required or situational. And then this particular document, this crosswalk, which is a great resource for you, also tells you item by item on a paper claim. If, let me just back up a minute. If there's a data element that is needed on the paper claim form, or information on the paper claim form, where does it go on that electronic claim form, that ANSI 837-5010? So if the information, for example, goes in item number 5 on a paper claim form, where does it go on that electronic claim form? Here I've just highlighted for you how you can find that information. It is on this crosswalk. There's a description of the data element, and you'll notice here there is a status column. You'll see some R's and S's there. Well, what does that mean? It tells you right at the bottom of each page of the crosswalk. An R means it's a data element that is required in order to process a claim. The S means it's situational. It only needs to be completed if other codes exist. So you'll find the requirements for the electronic claim over here in the right-hand column, but this is a great resource for you if your claims are rejected or denied. So let's get back to those top rejections. You'll notice numbers behind each of these reasons. That's the number of rejections for Specialty 17 claims in our jurisdiction for that time period I talked about, okay? Up until the date that the data was last refreshed. Here we go. The claim must be submitted to RRB. RRB stands for Railroad Retirement Board. In this case, the claim came to WPS, but it needs to be submitted to Palmetto. So pretty self-explanatory and easy to figure out. The next one, the next common rejection based on that data I pulled was, look at that first word. It says denied, but this is actually a rejection. Again, we can't control that it says denied when it's an rejection. This is the reason, and it's not maintained by WPS. Invalid or missing modifier. Well, where do you go for that help? Out on the WPS website, and there's links included in your materials for you. We have under there, we have a topic center at the top, and this provides for you the main sections of our website. Under claims, and you can also search for this, of course, look under claims and you will find modifier, choose modifiers, and here is a list of modifier fact sheets prepared by WPS that explains incorrect use of modifiers, appropriate use of modifiers, provides the definition. I just opened up the modifier 24 fact sheet, just picked one randomly. Appropriate uses, inappropriate uses, provides more information that may pertain to the use of the modifier, and so on and so forth. You'll see embedded links anytime you see blue on our website, so you can click and find additional information. There's some general modifier fact sheets, some fact sheets that pertain to use of the ABN, and then the rest are listed by category. One of the things that I like also about the use or these fact sheets is that some of them actually provide for you a list of codes that the particular modifier can be used with. So that's what you can do to fix or avoid invalid or missing modifier. Place of service conflicts with the procedure code, submit new claim. When this occurs, you need to check each of these. Check your procedure code. Maybe it was keyed wrong. Or check the place of service code that was submitted. We do maintain on our website a place of service list. I'm going to show you that. Just this time I'll search place of service. You'll see some matches come back. It's right here, place of service codes for professional claims. So this is how you can check to see if the code that you reported on your claim is correct, or if you need to fix it when you resubmit it. All right, let's look at more here before we move on to denials. Here are more common rejections, and remember, this is based on the data. It's only claims submitted by hospice and palliative care providers. Only one E&M code for service level covered per course of care. And this one, you know, is a little short, so it might seem a little cryptic, but that's what this means. Only one E&M code for service level per course of care. For this one, you would use or could use CMS Medicare Learning Network Evaluation and Management Services Guide for E&M guidelines and help. You will find information that pertains to billing for one E&M code for service level per course of care. Provides you with additional information in that guide, such as, what does Medicare consider same specialty or same provider rather, when you are billing in a group situation. Let's take a look at the next rejection there. This claim has been forwarded to Palmetto Railroad Board. This means that the claim has already been forwarded for you. There's no need for you to submit it to Palmetto. And this is based on a trading partner agreement. This is part of coordination of benefits when other insurers and benefit programs send eligibility information to CMS and they receive Medicare claims data for processing that supplemental insurance benefit. From the CMS National Crossover Contractor, and that contractor is the Benefits Coordination and Recovery Center. The trading partner agreement tells us at WPS, if this claim is rejected, then send it to XYZ. There's actually an agreement where that trading partner pays WPS to forward the claim so that the provider doesn't have to. Okay, now in this case, the situation is that it was a Railroad Retirement Board beneficiary. For beneficiaries who have retired from the railroad, their Medicare claims aren't processed by the MAC. They are processed by the Railroad Retirement Board, a special contractor. And in this case, it's Palmetto. You can tell if a beneficiary is one that has railroad retirement benefits by looking at their card. You need to look at the Medicare card. There's a banner across the bottom of that card that says Railroad Retirement Board. In that case, submit that claim to Palmetto, not to WPS. Facility or lab name and address or PIN is missing, just a couple of rejections there. You need to include, when billing lab services, the name and address or PIN on your claim form, and I'll point out the resource you can use to get additional information about that a little bit later on during the presentation. Claim must be submitted to UMWA, United Mine Workers of America. In this case, it's similar to that special contractor for Railroad Retirement Board beneficiaries or railroad retired beneficiaries. In this case, you need to submit your claim to the United Mine Workers of America. This was a mine worker, this particular beneficiary, and their Medicare claims then are processed by not WPS, but by the specialty contractor for UMWA. CMS maintains a directory. It's an interactive directory on their website, and I've included the resource for you later in your presentation. You can click on a particular state, and it will give you a list of all the contractors and even medical review contractors for that particular state. So that's just one of the resources so that you can fix or correct these rejections and later denials that I'll talk about. Another one of the rejections that says denied is invalid or incorrect ICD-9 code. Resubmit as a new claim. So you need to look at that ICD-9, which is outdated. I know that it's ICD-10, but I've included this for you because that's the way this particular reason code prints out. But in this case, take a look at that ICD-10 code. Maybe it was keyed wrong, maybe it was an incorrect code, but you'll need to resubmit a new claim. So I've just talked about the top, revealed the common rejections by reason. I thought it would be interesting to provide for you the list of CPT codes for those most commonly rejected WPS claims. So you'll see a number of evaluation and management codes here, 99232 and 99214. Reasons for rejections of these codes is that the top reason is that the rendering physician number was invalid or missing on the claim. Now these codes, most of these codes, those that aren't cryptic, for example, really do, I think, a pretty good job at telling you what you need to fix and what you need to look at in order to resubmit that claim. Rendering physician number invalid or missing kind of speaks for itself. Look at that number, make sure it was keyed, make sure it was there, maybe it was missing. Maybe it was an invalid number because it doesn't match another provider identifier on the claim. It doesn't match up. Claim must be submitted to the railroad board. And again, I have numbers telling you how many claims were rejected. Another missing, incomplete, or invalid billing provider primary identifier. So look at the billing provider identifier and make certain it was keyed correctly. Make sure it was there. Make sure it was complete, you know, that you didn't drop one of the numbers in the identifier. Let's talk about 80307. This one, the top denial, is the CLIA number is invalid or missing. CLIA numbers, and CLIA stands for Clinical Laboratory Improvement Act. It's a law. CLIA numbers are required on claims, whether they're paper or electronic, for any lab that performs CLIA covered procedures, the procedures covered under that law. And I've included for you a resource later in the presentation. Otherwise, that claim is going to be rejected as an unprocessable claim. The 10-digit number, certification number, the CLIA certification number, must be placed in item 23 of the CMS 1500 form or the electronic equivalent. Only bill one unique CLIA number per claim. The other reasons this code was rejected was rendering physician number invalid, missing incomplete, invalid billing provider identifier, primary identifier. So very, very similar to the reasons the 232 and 214 codes were denied. Similarly, 99222 and 99223, initial hospice, or excuse me, hospital inpatient or observation visit, similar. Rendering physician number invalid or missing, claim must be submitted to the railroad board, and only one E&M code for service level covered per course of care. There's where that one came in. Similar, the 99231 and 99232, but another reason these were rejected, the 231 and 232, is that the PA, NP, or CMS that billed the service was not internally associated with the billing provider number. And I see that the 99232 was not included on this slide. I do need to tell you there was a typo and not caught during the review and approval process. Look at the 4th bullet and the 9th bullet. It's 99223. The second one should be 99232, and I apologize for that. 99349, this is one where we had rejections because the place of service conflicts with the procedure code. And the other reasons were those invalid invalid rendering physician numbers and missing or incomplete provider identifier, primary identifier. 99497, this is advanced care planning. The clinic number is missing or wasn't entered correctly. And then again, we have the rendering physician number invalid and missing, and the claim must be submitted to railroad board. And the 99204, that new patient office visit, also rejected because one E&M code for service level is covered per course of care. So we talked about reasons. In the advertisement, I mentioned that I'd also reveal denials. There was reasons for denials. Take a look at this slide. You will see two of the most common denials for hospice and palliative care provider claims is because the charges were duplicate. We have a great resource on our website that talks about how to fix denials, and it categorizes denials by various categories such as duplicate denials or bundling denials. Make certain you're waiting, you know, at least 30 days, if not 45 days. Remember, Medicare has that payment floor. We can't send payment out. We have to hold that payment for a certain amount of time. If you're using a billing service or you have a mechanism set up in or a procedure in your office where you just automatically resubmit that claim every 30 days, you need to stop doing that. Repeated submission of duplicate claims is considered abusive. It costs you money. It costs Medicare money. So discontinue that practice of automatically submitting on a cycle a service if Medicare hasn't made payment for it yet. or sent you the RA with that information. Collection of fee-for-service during periods of managed care, 5 denials. What this means, folks, and it's a bit cryptic too. In fact, I had to ask someone in Medicare that's more familiar with these reasons than I am, or what prints out on that remit. I don't see a lot of remits. We do provide education about it. What this means is that patient has a Medicare Advantage or Medicare managed care plan. So the claim needs to go to the Medicare Advantage plan, not to WPS. That's a situation where you're going to have to check eligibility for the patient in order to determine their Medicare eligibility and where to send your claim. You can do that using self-service tools that are available. Services denied because the patient is in a hospice, 6 of them. We have resources available on our website that talks about the hospice benefit. A patient electing hospice waives their rights to services that are related to treatment and management of their terminal illness. So this waiver is in effect when the hospice election is in force, and it is up to the provider to determine correct billing. So make certain you're checking that eligibility information for your patient. Claim must be sent to the employer group health plan first. This is a form of a Medicare secondary payer denial. We have resources on our website about Medicare secondary payer. Pulling some of that over right now. Here we go. Pull over a lot of it. Again, you're going to look under claims, and I'm just showing you some of these resources, but there are links embedded in your handout materials. Again, if you go to the topic center under claims, you will see listed under our guides and resources, Medicare secondary payer. We actually have 4 items out there, so you can choose any of these to open and view information about the Medicare secondary payer program, the MSP program or MSP. There's also a number of recordings available on the WPS YouTube channel. Some great recordings that explain the Medicare secondary program, the various health plans that relate to it, and it will help you submit claims correctly. So in this case, this was a beneficiary, and again, you would check eligibility files to determine this. You would go to the eligibility to see where you need to send your claim first. Is there another insurance that's primary to Medicare? So that's MSP, and those resources I talked about will help you with those. More common denials, the timeline or time limit for filing your claim is expired. No appeal right. Again, out on the WPS website, I'm just going to type in timely filing here. We have timely filing of claims. This explains that you have 1 year from the date of service to submit your claim. Patient tells you you can only collect up to 20% of what Medicare would have paid if your claim was timely. It also tells you, and this is one of those exceptions I talked about at the beginning of my presentation, these do not have appeal rights. If your claim denies because it's beyond time limit, it does not have an appeal right. However, if you believe that you have reason that we should consider and reopen a claim for timely filing, or claim denied as timely filing, it tells you here how to do that. It is part of the internet-only manual, where CMS does state that third-party payer errors in making a primary payment determination does not constitute good cause for the purposes of reopening a claim. So this is some information that you might find helpful if you find yourself in those situations where your claim denies due to timely filing. Duplicate charges, here's another one. So 3 of the most common reasons for denials is duplicate. So we need to avoid those. Costs everybody time and money. Not covered when performed, referred, or ordered by this provider. There is a resource I've listed for you. I'll point it out here in just a minute, that talks about or gives you, it's a CMS resource, gives you all of the providers and identifiers of those providers that are eligible to refer or order services. So a great resource for you. Duplicate there, deny hospice service when provided by a non-attending physician. Those resources later provided will give you the information you need to avoid these types of denials. They're actually resources that are available on our website. And finally, denied service and units of service are exceeded. This is those National Correct Coding Initiative medically unnecessary edits. There is a limit on how many services you can bill on one day for the by the same provider for the same patient. Most of these are public, but some of them are confidential due to the potential for fraud and abuse. But you would use those edits, and I'll show you the resource in just a minute, or where you can find the resource that tells you how many units of service you can bill on any given day. So, for example, if you bill 7 units of a service that has an MUE edit of 5, Medicare is only going to pay 5. However, you can request an appeal, provide the documentation and justification that you believe should allow you to receive additional payment, and we'll consider that on an appeal. So here then are the commonly denied codes. 99233, 99232, most often denied because the patient had managed care, a Medicare Advantage plan. They also most often denied for duplicate and for providers that weren't eligible or certified to perform that particular service on that date. 99497 is duplicate, and again, managed care, or claim must be sent to the primary insurance first. So really, as I'm looking at these reasons here in my speaker's notes, I can tell you that for most of these denials, they're all denying the same. Duplicate, managed care, a couple of them are timely filing. We talked about that one already. Or denied because the patient's in a hospice, other insurance primary to Medicare. The other one that I see is frequency. That is the G0316. This denied because units of service were exceeded. That's those MUE edits. Denied due to duplicates and frequency. So there's frequency guidelines for this particular service, and the service was denied for that reason. Now, if you appeal that service, you would need to provide documentation when you request to appeal and show Medicare in that documentation, or point out why the service should be paid and not denied. All right. Now, remember I mentioned to you earlier that this data that we pull can actually be broken down in other ways. I looked at all 6 of our states. You can actually break down to county. We can also look at trending. So I do want to show you an example of that. This is a data trend for a denial. We can pull a report, and I didn't mention this earlier, but when I look at this data and I put the various things I'm looking for, which states are you looking for, which specialty are you looking for, then I can drill down which codes are you looking for. It's just a matter of clicking a button and that information comes back. There's not a whole lot of claims that have been rejected and denied for your particular specialty. Some specialties have thousands of claims that are rejecting and denying. For this specialty, specialty 17, they were far less. But in that 3-month period, the data trending shows that the current 3-month claim count for this denial, time limit for filing has expired, no appeal right, was 60. This particular report we look at will show the 3 months prior was 11. That's a difference of 49 claims. So you can see the difference between the current 3 months and prior 3 months is 445% increase in claims. So this, folks, just helps us analyze claim rejections and denials, tells us what we need to include in our education and what we need to focus on. And remember, I took you out to that article and showed you some of the information in the article that speaks to timely filing. That, folks, is why, because we've seen an increase in the past 3 months time of 445% for this. All right, so here then are those resources and tools. Many of them, here's those claim form instructions I talked about, and that crosswalk that I showed you. If it goes in item 19 on a paper claim form, what data element do you need to fill out and what do you need to put in there on an electronic claim? So that's requirements for Medicare claims. Here is the resource for rejections that we have on our website. You can see what it looks like over here on the right. This link will take you to a list, and it's listed by remarks codes. So those reason and remark codes I talked about earlier, like the MA130, you can look up reason and remark codes in this resource, and it will explain to you how to fix and resubmit that claim. So that's remark code, or that's rejections. I also wanted to give you a great resource for denials, and this is the one I talked about earlier, also on our website, that breaks down by category reasons for claim denials and how to avoid them. This is that one that talks about duplicate claims and bundling. There's entitlement denials. You can see provider number denials, because a lot of the claims that are denied due to provider eligibility issues. And many of those, indeed, based on the data that I just presented to you, did have to do with an invalid number that was being submitted or invalid primary identifiers. So looking at these resources tells you how to avoid those situations. There are more WPS resources, of course, our website in general. We had some data show that your specialty claims were denied because of Medicare secondary payer issues. So I included the questions and answers link here for you, or link to that page on our website. I also showed you, go out to that topic center, find claims, and then you will see those 4 resources for MSP. We have a live events webpage that lists the upcoming education events, similar to this webinar today. We continue to offer webinars based on those survey results that we get when you fill out your surveys. It's just one reason why that survey is so important. Give us suggestions for future education. If you want education on specific modifiers, for example, that are used for your specialty claims, let us know that. In fact, I think some of you did. So if you made those suggestions when you registered as a topic you'd like to see in the future, or one that you thought I would be covering today, but my advertisement didn't say I would cover, this would be the time in that survey to give us that feedback. But if you made a suggestion when you registered for today's event, I've already placed that out on our list of topics to consider. Encore presentations are the recordings of our website. You can actually go, or of our website, recordings of our presentations. You can go to the Encore presentations webpage and click on an Encore. We keep them out there for 90 days. Those are recordings, and a player will play that right then and there. You don't actually have to go to YouTube, but if you'd like, you can view the WPS YouTube channel for lists of all of our recordings. There's many of them. Remember, we call those encores, so look for that word encore in the name of it. Then you'll know it's a recording from a live event. But we have other videos out there as well. We have information about Medicare Advantage plans. You know, how do you know you should submit the claim to that Medicare Advantage plan, instead of to WPS? We have playlists for evaluation and management services. Remember, only one of these codes can be covered, during a course of treatment. That's the kind of education you're going to find when you go to the playlist and find an evaluation and management service recording that would include that type of information. And I'm just using that particular one as an example. There are scores of videos out there that pertain to evaluation and management. Billing services during a hospice election. This is one of the resources that I told you was on our website to help you determine who to submit when you submit a claim to Medicare if a patient has elected hospice coverage and when you don't. So that would pertain to submission of claims for those patients. during a hospice election. We also have a resource on our website titled Attending Physician for Patients Who Elect Hospice Coverage. This is going to include information about modifiers that you need to include on your claim. I've included the link to that timely filing webpage I showed you. And a couple others too. I know that some of you likely belong to specialty organizations or societies. If you attend regular meetings, or if you know that your society or association hosts yearly conferences and you want to partner with us, you want to invite someone from WPS to speak at your event, whether it's virtual or in person, use this link that talks about partnering opportunities. If you want further drill down of information that pertains to the rejections and denials of your claims, I looked at those that are most common, or your particular at your office or clinic, you can request that information, although there may be a charge by using look at this link. You'll find information about our release of information based on the Freedom of Information Act, and that will also explain any fees that might be associated. Here are CMS resources, that wonderful Evaluation and Management Services Guide. Remember, there are quite a few recordings in on our YouTube channel. CMS maintains a hospice center, everything you could want to know about hospice, out on their website. Here's the link. Those medically unlikely edits, those claims that are denied because they exceed the MUE, this tells you about those edits. It shows you where you can get to the edits and see how many of this CPT code Medicare is going to allow on any one given day. Remember that some of them some codes don't appear on that list, though some are confidential. I've also included the link on how to use the NCCI tools. We've also done some live events about this that walk you through the steps or talk you through the steps. So you can also look at some recordings on our website to find NCCI related information. Here's that data set for ordering and referring providers. Lists providers that are eligible to order and refer, gives you the name and the identifier for such, because those were some of the, I don't remember if they were rejections or denials, but if your claim rejected or denied because you were missing a referred provider, or it was invalid, or they weren't eligible, that's your resource right there. I've also included a link to one of CMS's Medicare Learning Network fact sheets. The product number is MLN 8816413, and this is a CMS prepared publication fact sheet that talks about how to check Medicare eligibility. How do you use those self-service tools would be something you'd look at on our website, because you'd be using our tool. But this just talks generally about checking Medicare eligibility and gives some tips. The IVR is a system, 24 hours a day, 7 days a week. There is limited functionality outside of business hours that will give you claim status and details. So this would be helpful to you. You can use our IVR operating guide to familiarize yourself with using this particular self-service tool available. You use your voice or the telephone keypad for this self-service tool. Here is a bit more information about that secure transactional portal that I've referred to several times today. Check eligibility, look at claim status, find claim details and claim actions. If you're looking at claim details, there is a button that appears. It says more info. If you click on that button and that particular claim line denied because of information in a policy, chances are when you click more information, you'll have the opportunity to click on a link to take you right to that portal. Or excuse me, that policy. I knew it was a P word, so that it makes it really easy for you just to find more information and dig a little deeper. Like the IVR, 24 hours a day, 7 days a week, with limited functionality outside normal business hours. If you are on the WPS website, you can easily find that portal user manual right here. There's a link to that user manual on every single page right up here under where you can log in if you are a registered user to use that portal. There's that portal user manual. Remember, illustrations, step-by-step instructions. All right. This brings us to questions and answers, but I am showing right now we are at 11 a.m. So if you can bear with me, folks, I will let you know how you can submit your question. I promise to answer it. I'm going to allow you up to a week to send them. So I will either send you an answer in an email directly, or I will compile a list of all the questions and answers in the chat and that I receive within the next week. Presentation related questions, that is, not claim specific questions that needs to go to customer service. I will compose or compile that list and send it out to everyone. One last thing, our greatest compliment, folks, is when you recommend our education to others. Please help us reach our goal to provide current and effective education for all those in our jurisdiction. Consider recommending our education to others. On behalf of myself and Alan and our entire provider outreach and education team, I do want to thank you for your participation. We look forward to your survey comments, and we hope to have you join us in the future. You may now disconnect. Thanks, everyone.